Hello, my name is Mike Pringle and I'm an ENT consultant here at the Queen Alexandra Hospital. This video is about the management of nosebleeds or epistaxis. It's aimed at doctors with no ENT experience just starting out in their ENT posts. An epistaxis is the commonest ENT emergency. Most people in their lifetime will experience one and they're usually small, self-limiting and easily controllable. However, occasionally they can be torrential and life-threatening. So epistaxis must always be taken seriously. We will discuss the anatomy of the nose, the possible causes of epistaxis, and the management of a patient with an epistaxis, which follows the standard principles of general assessment, first aid, history, examination, investigations, and treatment. Not necessarily in that order, but all areas need to be covered. The nose is a triangular-shaped cavity with the apex superiorly and the base inferiorly, and divided into two halves by a midline partition called the septum. The nasal cavity extends about 7 to 8 centimetres into the face. On the side wall of the nose, there are bony shelves covered with an erectile mucosa called turbinates. It's very important to note that the floor of the nose lies on a horizontal plane. Patients have a tendency to tip their head back when being examined or having packs inserted. Try and keep the head in a horizontal plane. In order to ensure a pack is inserted in the right direction, it's important to keep the head level with the floor of the nose in the horizontal plane. One of the functions of the nose is to warm the air we breathe in, and in order to do this, the nose has a very rich blood supply. 5 arteries supply the septum. 2 are branches of the internal carotid, and 3 are branches of the external carotid. These arteries all anastomose in the anterior septum in an area known as Little's area. About 80% of epistaxis come from Little's area. The lateral wall of the nose also has a rich blood supply. The causes of epistaxis can be divided into local and general causes. Local causes include trauma, inflammation, structural abnormalities, drugs and tumours. The commonest form of trauma is repeated nose picking, but also nasal surgery, nasal fractures or skull base fractures can cause epistaxis. Inflammatory causes include allergy, infection, nasal polyps and Wegener's granulomatosis. This image shows a septal perforation which may bleed from the edges. In the initial stages of treatment, intranasal steroids can cause bleeding. Tumours in the nose are very uncommon, but the initial presentation could be with an epistaxis. For the majority of epistaxis, the cause of bleeding is unknown or idiopathic. First aid. If the patient is actively bleeding, you need to initiate first aid measures to try and stop the bleeding. The patient should be seated, leaning forward, with the neck flexed and a bowl held under the mouth. They should be encouraged to spit out any blood which goes into the throat because swallowed blood can cause nausea and vomiting. The nose should be pinched at the lower, soft part. Pinching the nose in this area achieves 2 aims. It applies pressure directly over Little's area, the commonest site of bleeding, and it closes off the nostrils so that no blood can escape through them. Any bleeding that continues despite this manoeuvre will fill the nasal cavity and clot. The digital pressure needs to be maintained for about 10 minutes without letting go. After a couple of minutes the fingers will get tired and the patient should swap hands or get someone else to press the same area. The incorrect way to try and stop a nosebleed is to press on the nasal bridge and lean backwards. As these images show, pressure on the nasal bridge has no influence as to what is happening within the nasal cavity, and so is completely ineffective at stopping nosebleeds. The pressure should be applied lower down over the soft part of the nose. General assessment. At the same time as performing first aid, it's important to assess the patient's general condition. Are there any signs of trauma or associated head injury? Are there any signs of shock? Is the patient pale, sweaty, cool and clammy, tachycardic, lightheaded or confused? If there are any signs of shock, or there's a history of excessive bleeding or active bleeding, then a large bore cannula must be inserted and intravenous fluid started. It is very important that a shocked patient must not leave the A&E department without first being resuscitated. While performing first aid in the general assessment, you will start taking the history. It's important to know when the epistaxis started, how long has it been bleeding for, and which side is bleeding. Ask the patient to estimate the amount of blood loss. For instance, would the blood fill an egg cup, a cup or a bowl, or would it soak a handkerchief, a face towel or a towel? Is it bleeding mainly down the front or down the back into the throat? Is there any history of trauma? Is there any past history of hypertension, liver disease or clotting problems, either in themselves or the family? What is their alcohol intake? And are they taking any medication, such as warfarin, aspirin, non-steroidals or clopidogrel? Examination. Hopefully the blood pressure and pulse will have already been checked. If not, you must check them. Look at the patient's face for any signs of hereditary hemorrhagic telangiectasia or liver disease. Before examining the nose of a patient with an epistaxis to try and identify the site of bleeding, you must get yourself prepared. You must protect yourself. A patient with an epistaxis may sneeze or cough, sending a spray of blood all over you. It's important to have a gown, gloves, mask and eye protection. You will need a headlight and suction and a local anaesthetic such as cofenalcane, which is a local anaesthetic nasal decongestant mixture. You'll need a tongue depressor to examine the throat and a McGill's forceps to remove any clots from the back of the throat. You'll need some Tilly's nasal dressing forceps and a Thuddicom's nasal speculum to examine the inside of the nose. You'll also need some cotton wool, some silver nitrate sticks, some Naseptin cream and some Mericel nasal packs. Sit the patient with their eyes looking straight ahead so that the floor of the nose is in a horizontal plane. The Thuddicom's speculum is used to examine the nose. It takes a bit of practice to use this instrument correctly. Use the suction to remove any blood clot from the nose. If the blood clot is deeper within the nasal cavity, then a smaller suction end will be required. Spray the nose with the cofenalcane spray. This spray not only gives local anaesthesia, but the decongestant causes the nasal lining to shrink, allowing a better view of the nasal cavity. While the spray is working, examine the back of the throat to see if there are any blood clots which should be removed using the McGill's forceps or suction. Examine the nose to see if you can identify a bleeding point, looking carefully at Little's area. The appropriate treatment depends on your findings. It's very important when treating a patient with an epistaxis to have a nurse to assist you. It's not uncommon for the patient to faint. If the patient has had a minor bleed which has stopped bleeding and no bleeding point can be seen, then the treatment will be with simple Naseptin cream and education about the appropriate first aid measures. If you find very prominent vessels or a bleeding point in the Little's area, the treatment will be with either silver nitrate cautery or bipolar diathermy. A raised vessel found more deeply into the nasal cavity may well be arterial and the treatment should be with bipolar diathermy. Silver nitrate cautery may well be insufficient. If the bleeding is mainly anterior and no obvious bleeding site is seen, or if silver nitrate cautery has failed and the bleeding is ongoing, then the treatment will be with an 8 cm Mericel pack. If the bleeding is mainly posterior and there is no obvious bleeding point seen, then the treatment should be with a 10 cm Mericel pack. If the bleeding is not controlled by a Mericel pack and is mainly anterior, then a bit pack alone may be sufficient. However, if the bleeding is not controlled by a Mericel pack and the bleeding is mainly posterior and profuse, then a bit pack and a Foley catheter should be used. Investigations. Every patient with more than the minor bleed should have a full blood count performed. If the patient is on warfarin, the INR must be checked. A clotting screen is only necessary if there is a history of bleeding disorder, a family history of bleeding disorder, a history of increased alcohol intake, or liver disease. Other blood tests may be required depending on the patient's medical history. Silver nitrate cautery. If the bleeding point can be seen on the septum, it's probably worth attempting silver nitrate cautery. An alternative, if you have it, would be to use bipolar diathermy. The septum will need to be anaesthetised, and the best way to do this is with a piece of cotton wool soaked in either a local anaesthetic decongestant mixture, such as cophenolcaine, or soaked in simple lignocaine spray, which can be put into a gallipot. In order to avoid developing a numb lip, the patient should be given a tissue to catch any local anaesthetic that may drip out of the nose. Keeping the head level, with the floor of the nose in the horizontal plane, open the nostril with the thudicum speculum and insert the cotton wool so it's lying against the septum over the bleeding point. Leave the patient for 10 minutes for the anaesthetic to work. After 10 minutes, remove the cotton wool. Use the thudicum speculum to expose the bleeding point. Use a silver nitrate stick and start by creating a circle around the bleeding point and then working in towards it. When you get to the bleeding point, press on it for about 10 seconds. The septum will turn white when it comes into contact with the silver nitrate stick. Never cauterize both sides of the septum in the same area at the same time. Once you've finished, if the patient has no allergies, you can apply naseptin cream. This can be applied by putting some cream on the end of a cotton bud and gently wiping it over the cauterized area and also over the skin of the vestibule, where the hair follicles may be harbouring bacteria. You should advise the patient to stay in the waiting area for about 45 minutes. You should instruct them on first aid techniques, and you should advise them to avoid any strenuous activity, to avoid scratching the area, and to avoid very hot baths or showers over the next few days. Mericel. If silver nitrate is unsuccessful, or if no bleeding point is seen and the bleeding is continuing, then a nasal pack will be necessary. The Mericel pack comes in two sizes, an 8 cm and a 10 cm. For a mainly anterior bleed, which is not too severe, use the 8 cm pack. If there is also any posterior bleeding, or it's more severe, then a 10 cm pack should be used. The 10 cm pack will extend through the posterior choani and close off the back of the nose. The Mericel pack is a firm, dehydrated sponge which must not come into contact with water before it is inserted into the nose. If both sides of the nose are bleeding, or you're not sure which side is bleeding, then both nasal cavities can be packed. You must have a nurse to assist you, as it's possible that the patient may faint. It's very important that you make sure you're wearing gown, gloves, mask and eye protection. You'll need a tongue depressor and a McGill's forceps to remove clots from the back of the throat. You'll need thudicum speculum, suction, local anaesthetic, Mericel packs and naseptin cream. Keeping the head level with the eyes looking forward and the floor of the nose in the horizontal plane, clean any clots from the nose using the suction. Then spray the nose with the local anaesthetic spray. If using pure lignocaine, warn the patient that it may sting. Also warn the patient that it may go down the throat and make the throat feel numb, so hot drinks should be avoided for a couple of hours. If there are no allergies, just before inserting the Mericel pack, it can be covered with naseptin cream or a lubricating gel, though the gel will start to rehydrate the Mericel, so you need to act quickly. Again, keep the head level with the floor of the nose in the horizontal plane. It's useful if a nurse can support the back of the patient's head. The pack is grasped between your fingers and inserted into the nose at about a 45-degree angle. It should be advanced to about 1 centimetre, then rotated to lie on the horizontal plane and reasonably quickly pushed all the way into the nasal cavity. The Mericel then needs to be rehydrated. Take a 10 ml syringe filled with saline and a green needle. Insert the needle into the end of the Mericel pack and slowly inject the 10 ml. The patient should hold a bowl under their chin to catch any saline that may drip out. Secure the tie on the Mericel pack to the nose or the cheek. The tie must not press against the alar margin, as it may cause alar necrosis, resulting in an unpleasant deformity. If both sides have been packed, the ties can be tied together. The pack should stay in for about 24 hours. Before removal of the pack, it should be rehydrated using the same technique as described earlier. If the patient is very anxious, but otherwise healthy, a small dose of diazepam can be given. Elderly patients with bilateral packs need careful observation as they may become hypoxic. posterior packing with bip and Foley catheter. If the Mericel does not stop the bleeding, or the bleeding is profuse, then a bip ribbon gauze pack may be required. If blood is going down the throat, the bip will need to be combined with a posterior pack such as a Foley catheter. You must have a nurse assist you, as the patient may faint. It's essential to make sure you're wearing gown, gloves, mask and eye protection. You'll need a tongue depressor and McGill's forceps to remove any clots from the back of the throat. You will need a thudicum speculum, suction, a local anaesthetic, Tilly's nasal dressing forceps, a Foley catheter, a bip ribbon gauze dressing, a 10ml syringe, 10 ml of saline and an umbilical clamp. There are many ways to secure the Foley catheter. One is to cut off the outflow port and then slide it along the catheter large end first. Prepare this before you start. Keeping the head level with the floor of the nose in the horizontal plane, examine the throat and remove any clots which may be seen hanging down from the postnasal space. If the patient has a Mericel in place, rehydrate it before removing it. Rehydrate it by slowly injecting 10 ml of saline into the pack and then waiting a few minutes. Pull the Mericel out. Remove any clots from within the nasal cavity with suction. Examine the nose again for any bleeding points. Keeping the head level, with the floor of the nose in the horizontal plane, spray the nose with local anaesthetic, preferably cofenarcane, which contains a decongestant. Keeping the head level, slide the Foley catheter along the floor of the nose, and if you can, visualise the tip of it coming into the oropharynx. If you can't visualise the back of the throat, ensure that at least 10 centimetres of the catheter has been inserted. Then slowly inflate the balloon with 7 to 10 centimetres of saline. Withdraw the catheter so that the balloon lodges in the posterior choana. Ask the nurse to hold the catheter under tension. The balloon will be closing off the posterior choanae, sealing the back of the nose. This should prevent any blood from leaving the back of the nasal cavity, so that any continued bleeding will hopefully collect within the nasal cavity and tamponade itself. The Foley catheter posterior pack is combined with a bip anterior pack. Grasp the bip ribbon gauze about 10 centimetres from the end with a Tilly's nasal forceps. Ask the nurse to support the head. Keeping the head level with the floor of the nose in the horizontal plane, insert the bip along the floor of the nose. This creates a double layer of bip. Remove the forceps and grasp the bip ribbon gauze about 8 centimetres from the nostril and insert another layer above the first layer. In this way, continue to layer the bip, working superiorly. Once the nasal cavity is full, then fill the vestibule, which is the area just inside the nostril, with any remaining bip. Cut off any excess bip. You're now left with the two ends of the bip ribbon gauze protruding from the nose. Pack these into the vestibule. Ideally, in the example on screen, a little bit more bip could have been packed into the vestibule, so the packing was left just protruding from the nostril. As you will see, this is to avoid the catheter from touching the alar margin. Slide the catheter outflow port along the catheter to lie against the end of the bip dressing. Keeping the Foley catheter under tension, apply the umbilical clamp. This stops the catheter from moving and ensures that the posterior choani remains sealed. In this example, because I did not use quite enough bit packing, the catheter can be seen touching the alar margin. This risks alar necrosis. In order to correct this, a piece of gauze was inserted to keep the catheter away from the alar skin. The remaining catheter can then be taped to the side of the head or tucked behind the ear. If the patient is very anxious but otherwise healthy, a small dose of diazepam can be given. If the bleeding is profuse and bilateral, then this procedure can be repeated on the other side. Elderly patients with bilateral packs, especially with posterior packs, need very careful observation, using a PO2 monitor if available, as they may become hypoxic.